Hi, I'm Gwen Kiefer, Head of Digital Marketing, and your host for today's webinar. I'm going to give you a quick rundown of the agenda today. Today on Brain Matters, we will be discussing events coming up in 2018 in the neurocritical care world, literature on neonatal brain monitoring brought to you by Dr. Anna Rodriguez. We are pleased to have our featured panelist, Kathi Salley Randall, along with our featured industry partner, CSE, a Gentherm company, followed by an overview of the features for neonatal brain monitoring on the Moberg CNS monitor. At the end, there will be a Q&A session to answer all your questions you have posted in the Q&A tab. So please post away. Thank you, and please enjoy Brain Matters. Here are events coming up in 2018. Thomas Jefferson University 7th Annual Neurocritical Care Symposium, January 26th through 27th, Philadelphia, PA. UCLA Critical Care of the Future, February 1st through 2nd, Los Angeles, CA. The One Conference, February 4th through 5th, San Diego, CA. ANIM, February 8th through 10th, Wurzburg, Germany. Training workshops aEEG and NIRS in neonatology and pediatric intensive care, March 23rd through 25th, Munich, Germany. Now, Dr. Anna Rodriguez, Director of Research, will be giving an update on literature.
And now, an update on recent papers on neonatal neurocritical care and EEG. In this first paper, Dr. Kathi Salley and colleagues present the results of a study about the use of EEG in pediatric and neonatal ICUs in the United States. Using information extracted from the Kids Inpatient database, they revealed that among common indications for EEG monitoring in critically ill children and neonates, the proportion of patients actually having an EEG is still low. Other interesting findings are offered by Dr. Wusthof and colleagues, who surveyed practices and opinions about services related to therapeutic hypothermia in the state of California, confirming the existence of wide variation in the implementation of these services. The group of Dr. Boland in Cork, Ireland, published a research study on seizures in preterm infants. Data was collected using the Moberg CNS monitor and other equipment. Based on the results, they conclude that continuous EEG monitoring is key to the accurate detection of seizures in this population. Dr. Chalak from the University of Texas Southwestern Medical Center presents her interesting research on cerebral autoregulation and neurovascular coupling in neonates with encephalopathy. In particular, she describes a new wavelet analysis of EEG and near-infrared spectroscopy to provide information in multiple timescales. Last but not least, Dr. Girl and colleagues report on the ability of Amplitude EEG and near-infrared spectroscopy to predict outcome in neonates with hypoxic ischemic encephalopathy.
I'm pleased to present our panelist, Kathi, a leading neonatal nurse. Kathi, please take it away.
Thanks, everyone, and good morning to wherever, or good afternoon, depending on where you are in the world. It's my pleasure to be with you and to be part of the first Brain Matters Symposium online. And I'm just going to quickly share my screen so that we can follow along with some slides. And if you can just confirm, Gwen, that all looks good in full screen or maybe in the Q&A. So I always like to ask who everybody is and where they are. So so if you want to type in the Q&A area, I'll look later and see where you all are and if you're already using monitoring. But again, I'm excited to be here and talk about one of the things that I'm really passionate about. So this is really titled Bedside Brain Monitoring in the NICU. And although I could talk about this topic for hours, they've tried to constrain me to only a few minutes. So I'll do my best to cover what I hope to to share with you today. So great, cool. Nice to see all of you here. So welcome to everybody who's watching the recording as well. So let's just dive right in. So when we think about the way that we care for babies in the NICU, we really do monitor them from head to toe. We use, all sorts of different monitoring, and really until the last decade or so, we didn't really think much about what was happening happening above the clavicles. So we would monitor, and we still do monitor, temperature, end-tidal CO2, saturations, usually from more than 1 or 2 places, respiratory rate, heart rate, blood pressure. We can do invasive and non-invasive monitoring. But really, when we think about it, what were we monitoring about the brain, the organ that we know is responsible for really our quality of life? So when we think about the NICU and the neonatal brain monitoring that are available for us, we really can break them into 2 categories. And so this would be our brain function monitors, and then we can have, sorry, this little panel is kind of in the way, the brain function monitors or brain perfusion monitors. And so most commonly we would think of near-infrared spectroscopy as being that as well. So I'm going to just stop my video because I think it will help the recording. So when we think about these kinds of monitors, let's talk about some of the pros and cons of using them. Well, and what the goals are. So first off, with bedside brain monitoring, this is what I'm thinking about for someone who's unit-based, a clinician, a physician, a nurse practitioner. This is something that we would use. So bedside brain monitoring really complements everything that we already do, and it's really a tool for the bedside provider day in and day out to use. It should never be really considered a replacement of other kinds of important neuroassessments, but it should be really used in conjunction with those. And what I think the benefit of bedside brain monitoring really is that it provides unit-based clinicians information day in, day out, real-time information, so that they can see that the interventions they're providing actually, the impact those are having on neurological performance. So what are some of the advantages and disadvantages? Well, we know that continuous video EEG is our gold standard for seizure detection and for other types of things that we might be wanting to investigate about the cerebral activity. We also know that 80 to 90% of neonatal seizures have no clinical correlate. So we need to monitor to have that electrographic information in order to actually diagnose and to treat those seizures. We also know that once a medication is given for a seizure, that oftentimes we see an uncoupling or an electrical mechanical dissociation, where even though we thought we saw seizures, now we've given a medication and we no longer see that. So we know that having a tool where we can actually look at the electrographic nature of what's happening can actually help us guide care even better. The disadvantage of continuous video EEG really is in the extensive amount of electrode application and then the interpretation of the immense amount of data that we get. And we know that although it can be reviewed remotely, that it's oftentimes difficult to have the services we need, when we need them. So this brings those bedside brain monitors, and specifically one of my favorite tools, Amplitude integrated EEG. And using just a simple small number of electrodes, we can get an overall impression of cerebral activity. The advantages: easier to use. So something, especially if it's a standalone device, it's easy to use, minimal interference, and less training required. But the disadvantage is it's only a few electrodes giving us a limited view. We might miss some seizures, and that depending on how often you use it, there may be some slow uptake of the confidence and people's confidence in using Amplitude integrated EEG. So we know that there is complicated monitoring, and then there is simplified monitoring, and we're going to talk about some, combinations of that later. Near-infrared spectroscopy, or the cerebral perfusion monitoring, or oxygen saturations, I like to think of them as cerebral or end organ saturation monitors, are another non-invasive tool that we can begin to get more information about perfusion and uptake of oxygen in the different areas that we might be monitoring. And we can put these probes, you can see a little picture here, on multiple different parts of the body. In the literature, we can have a reference point for normal values for our term and our preterm babies. And what most people now believe is that a sustained cerebral saturation, regional saturation of less than 50 is noteworthy, reportable, and even worth potentially finding an intervention, because we know that at levels that are sustained at less than 40%, we'll have actual cellular injury in our animal models. And then, of course, on MRI patients, or MRIs, we see for cardiac babies that we also do see MRI changes and some chronic hypoxic injury on those particular patients. So in the end, when we really think about that bedside neuromonitoring, what does it really tell us? Well, when we think about function, so whether it's continuous video EEG, aEEG, or other trends, we're really looking for that immediate and continuous evaluation of brain activity. What's the background? Is there presence of sleep? Is there presence of seizures? Then the other thing we want to do is use that information based on what we know in the literature to say whether or not that can correlate then to some outcomes for certain populations. The other thing, responding to treatment. So does the medication, does the treatment we're giving have a correlation to a change in brain function? So allowing us to, take, A plus B equals C, and really seeing whether or not what we think we're doing is actually having the impact we expect. And of course, anytime we can monitor or screen a baby's brain and find something that is abnormal or of concern, we would hope that we can intervene earlier so that we can then have a better outcome. And I was just looking at the paper by Dr. Abend up at Children's in Philly, and he was talking about how even just getting ahead of seizures from 3 hours to 1 hour can improve our ability to get a hold of that seizure burden. And that if we wait too long, sometimes even a second line and third time drug doesn't even work. So that earlier intervention really is aiming at getting better control as well as improving outcome. So when we think about brain function, those are the things we just talked about. We talk about brain perfusion, and then we can think about whether or not that's the brain hemodynamics, whether the brain is actually being oxygenated, not just our peripheral probe. Again, similar kinds of ability for us to predict outcome in some populations, responding and evaluating the response to treatment, and again, earlier interventions. So really the same type of utility once we get those numbers and can interpret them. So as we look at our NICU population, there are many babies who could benefit on a day-to-day basis for ongoing brain monitoring. And so we can think about our hypoxic respiratory failure babies who are potentially heading towards ECMO, hypotensive babies, anemic babies, cardiac babies, premature babies, and of course our other babies who have any kind of oxygenation or perfusion issues. Then when we think about our aEEG, specifically the cooling babies with HIE, even our mild babies who kind of on the fence, maybe they're worth monitoring. Seizures, prematurity, infection, and of course our cardiac babies, we know that they're also a very high risk group and that they have very abnormal EEGs, even pre-op. For today, since we're partnering in this presentation with Cincinnati Sub-Zero, it makes sense to talk a little bit about therapeutic hypothermia and really the place for the HIE baby cooling and monitoring. Where does it all kind of fit together? We know that therapeutic hypothermia, 33.5 for 72 hours, is now that standard of care. And we really do hope that everyone who is eligible is receiving this treatment. We also know as a disease process that HIE carries a high burden of seizures, especially subclinical seizures, which we already mentioned earlier. So when we think about this burden of seizure, we can think about these infants with HIE having a burden somewhere around 33 to 45%. But the big piece of this is down here at the bottom where we say this dissociation and subclinical. So 60, and some people estimate as high as 80% of seizures with HIE will be subclinical. We know, based on many other papers, that the routine EEG, that 30-minute spot check that we used to all give, is just not adequate. We know that seizures for babies with HIE have a very, very typical kind of onset. We know that they happen early, but can happen truly anytime during the cooling process, but also happen to a small degree during rewarming. And so definitely there's a risk that's worth monitoring during that time as well. We also know that there have been guidelines that are published. So Renee Shellhouse and colleagues put out the ACNS, or the American Clinical Neurophysiology Society guidelines, back in 2011, this talking about continuous EEG monitoring for babies. What babies are the highest risk? They list them out and then give some recommendations of best practices around when they should monitor. So for cooling babies specifically, they call out a minimum of 24 hours of monitoring. If there are no seizures, background pattern stable, you can stop. And then if, this is just for HIE, but with cooling, they're really recommending that full 72 hours. So, and then what I see in practice most is the full 72 hours and about 24 hours post rewarming. So rewarming and then for another 24. So seizures are common. So this is just a picture of an aEEG where you see some uprisings in the upper and the lower margins, and then just showing this baby's having repetitive seizures, which are quite obvious to be seen here on the aEEG pattern, and then confirmed by the spike wave pattern below on the EEG. So the other thing that we know is that aEEG for the cooling babies have been very predictive of outcome. And so we can look even to the paper by Mariana Thorensen from 2010, where we see that the positive predictive value of a poor aEEG early is predictive of poor long-term outcome. And that in that first 24 hours, we know that babies who are cooled, aEEG is not so predictive as it used to be in the normal thermic population. But when we get out to around that 36, 48 hours, we begin to see that there's some convergence right around that 95 to 100% predictive values, that if you have a sustained poor aEEG, meaning either burst suppression, low voltage, or flat, this is a very highly predictive pattern of death or disability. So again, a great paper, and I'm sure most of you have seen it. We know that NIRS is beginning to show promise in this population, and that what we know even more is that a combination of monitoring is even greater value, and has huge promise, not only for this patient population of the HIE baby, but also other populations as well. Which I think this is why we want to think about multimodal monitoring. When we can take multiple parameters, trend them together, and see them, then I think that we can do a better job of taking care of our patients. And so if you'll indulge me for just a couple more slides, I just want to show a couple just examples of just some displays that I've used in my practice that I find to be quite helpful. This is I didn't use real patient info, so just so that you know, but this is basically taking the Moberg device, which I love using for babies, especially during cooling, and really simplifying the display down to even just what we would have seen in the old days of the old Lectromed CFM, just a single channel. So we can be as simple as we want on the display. We can also get back to kind of the more modern look of aEEG, which is looking at two channels, so we can at least assess some symmetry between right and left hemispheres. So again, taking the display and modifying it to give you a little more detail. And then you can do crazy things like having the aEEG, the impedance, interburst intervals, and some of the other qEEG parameters that may also be available and helpful for some NICU populations. Most specifically, I'm thinking like preemies. You can change up the display by adding other cEEG kinds of trends like DSA, and still just having the displays that you want. So just completely customizable. And one of the ones that we really love in my NICU is actually looking at having the aEEG along with other neurovitals. So we have our aEEG impedance at the top here, right and left, and then we have our cerebral sat, we have a heart rate, and we have blood pressure. If a baby's undergoing cooling, we can have a full neurovital sign page, which we love to have at the bedside, giving us heart rate, blood pressure, peripheral saturation, regional saturation, and then of course trending the core temperature. And you can also trend the blanket temp and do great quality improvement reviews with that as well. So thanks for allowing me to go a couple minutes over and to share those slides with you.
Great, thank you, Kathi. That was great. Up next is our industry partner, and don't forget to stay tuned till the end for our Q&A session. Next, we have our partner, CSZ, a Gentherm company. CSZ Medical was one of the first companies to provide whole-body cooling devices to the NICU environment with great success. It is estimated that 2 to 3 per 1,000 births experience a hypoxic episode during the peripartum period. Of those, approximately 25 to 30% will have permanent neurological deficits as a result. Studies have shown that whole-body hypothermia can help reduce the risk of death or disability in infants with moderate or severe hypoxic ischemic encephalopathy. It provides homogeneous cooling to all brain structures, including peripheral and central brain regions, resulting in a safe and effective method for cooling infants. And now a clip from our industry partner.
Introducing the Blanketrol 3, a patient temperature management system with a user-friendly and programmable interface. With a triple hose design and integrated connectors to ensure proper flow rates for optimal temperature control. Providing your patient with consistent temperature coverage for quick temperature management. The Blanketrol 3 offers a consistent flow rate of 36 to 42 gallons per hour and up to 9 to 10 psi for efficient therapy, depending on the model. The faster the right temperature can get through the blanket, the faster your patient will receive therapy. And a user-friendly interface allows for programmable and preset variable gradient temperature selection. Every feature was designed and engineered to provide safe and consistent therapy for patients. And caregivers depend on effective heat exchange and patient temperature management for the controlled warming, cooling, or management of a patient's body temperature for a variety of therapeutic uses. The Blanketrol 3 works seamlessly with Cincinnati Sub-Zero Hyperthermia blankets and wraps, offering complete system integrity. From the control unit to the hoses and connectors, all the way through to the blankets, wraps, and pads. And the Blanketrol 3 operates at higher flow rates and pressures than other manufacturers to provide optimal flow to CSZ blankets and wraps, which use random flow patterns to ensure that proper water temperature is delivered consistently, regardless of how a patient is positioned. CSZ also offers blankets and wraps with non-self-sealing connectors to protect against leakage and help keep patients comfortable. Learn more about the Blanketrol 3 patient temperature management system at www.cszmedical.com.
Next, we will take a look at the neonatal brain monitoring features on the Moberg CNS monitor.
Hi, my name is Tracy Berlin. I'm a nurse and a clinical specialist focusing on advanced neuromonitoring technologies. Today, we will be featuring the Moberg CNS monitor, a brain monitor that goes beyond the typical monitors seen in the neonatal ICU. We will briefly cover EEG processing methods, integration of the Cincinnati Sub-Zero Blanketrol, and other key features that will take your brain monitoring to a higher level. As most of you know, EEG can be difficult to interpret by someone without advanced training. Yet it is important for clinicians at the bedside to recognize potential abnormalities in EEG in order to properly diagnose and treat the patient. Fortunately, several ways to process and simplify EEG have been developed. One of these is Amplitude Integrated, or aEEG. aEEG is well characterized and widely used for detecting changes in the EEG. However, it monitors only one aspect, amplitude, and it may not detect seizures of short duration or ones with minimal amplitude change. Monitoring multiple characteristics of EEG, such as frequency and patterns like burst suppression, can enhance the ability to detect abnormal events. Additionally, by time synchronizing EEG with recordings from other body systems, such as temperature and oxygen saturation, we can go beyond EEG to bring neonatal brain monitoring to a higher level. Let's take a look at the Moberg CNS monitor. The CNS monitor provides simple 2- or 4-channel monitoring like other conventional neonatal brain monitors. But in addition to these simplified displays, the CNS monitor can display a full 1020 montage EEG, eliminating the need for a separate EEG machine. The Amplitude Integrated EEG, or aEEG, can be calculated on any or all EEG channels. A variety of other quantitative EEG trends moves you beyond aEEG to explore other characteristics of the EEG signal. These quantitative EEG trends include frequency measurements, burst suppression indices, and amplitude envelopes. A unique feature of the CNS monitor is its ability to collect and time synchronize data from multiple monitoring sources, such as NIRS, vital signs monitors, cooling systems, and others. Connecting devices and customizing displays are easily performed by clinicians. Animated tutorials are embedded in the CNS monitor for additional reference. On this display, we see the integration of temperature data from the Cincinnati Sub-Zero Blanketrol with aEEG and other physiology. As we learn more about the role of temperature in brain function and use therapies such as therapeutic hypothermia, the importance of integrating temperature data with other physiologic parameters, including EEG, becomes apparent. The CNS monitor goes beyond data collection and functions as a complete data management system. With this system, you can archive and process data and create searchable databases for clinical and research applications. An additional component, the CNS Reader, further analyzes data and can accept application plugins, such as displays that quantify adherence to clinical goals. The brain has been referred to as a black box, the most important organ in the body, and the one whose complexities are continuing to be revealed. A multimodal approach to brain monitoring provides more information on what's happening within that box. Collection and integration of multiple physiologic parameters using the CNS monitor allows clinicians a powerful platform on which to base critical decisions in patient care.
Great. Now is our Q&A session. So if you have any questions for either us at Moberg or for Kathi, please post them in the Q&A right now and we will answer them. So post away. And if you have want any more information, you can always go to moberg.com and look at our website. We post about events coming up there, our past webinars, and a lot of different information and educational content.